So I think we have a pretty decent turnout. I'm sure people will still just slowly start to trickle in. So maybe I'll just start quickly with an introduction. So thank you everyone for coming to Medical Grand Rounds today. We have the pleasure of having a guest speaker. So Dr. Peter Anglin is a hematologist at the Stronach Regional Health Center or at South Lake in Newmarket, and he will be giving us a presentation about the Bispecific program at South Lake and how they implemented the program. So as I had spoken to some of you guys previously in medicine and ICU, the bispecifics are a type of therapy, cancer-directed therapy that is already has made its way to several cancer centers and community centers across Ontario. And at Scarborough, we're very excited and we're hoping to eventually implement these therapies at our site as well. So Dr. Anglin will give us a practical overview today to explain more about bispecific therapy as well as side effects and the logistics of navigating bispecifics. So I think we'll let him do the presentation and save questions for the end. We'll save about 15 minutes for questions, but I will also be moderating the chat. So if you have any questions, feel free to type it in the chat and I will keep an eye out for that. So without further ado, it's all yours, Dr. Anglin. Thank you so much for coming today.
Thanks, Jesse, for having me. Thanks to AbbVie for supporting this. First, just let me share my screen and then we'll make sure we get that piece done right. All right, so I'm almost there. Can you see my screen?
Yeah, we can see it.
And you can see my slide okay?
Yeah.
Okay. I've got about 45 minutes. We want to leave time for questions. Welcome, everybody. I've actually used to work at Scarborough Centenary, so I know community hospitals. And then I was out at Credit Valley. I was downtown for a while, and now I'm at the Stronach Cancer Center. We have a bispecific program up and running. It's been running for about a year. We were the second community hospital in the province to do it, and we've probably had a lot of learning over time. So I know there's a mix of generalists, internists, probably pharmacy and other people here. I'm going to just show you sort of why we're doing this. And here's the slide really of why we're doing it. This is a New England publication 3 years ago, myeloma, people with 5 lines of therapy. And they got one of these bispecifics, teclistamab, and about 63% of patients responded. And about 2/3 of those were in complete remission. And about the average duration of progression-free survival was 1.5 years. So this kind of thing is unheard of in cancer, let alone hematology. And so this is the kind of data these drugs are generating, the results they're getting, and that's why there's real interest to implement them in a number of disease sites. Today, I'll give you a little background. I'll talk about the drugs that are available. We'll talk a little bit about the cytokine release syndrome and the ICANS or the neurological issues, because on titrating up these drugs, the first 2 or 3 doses, there's a higher incidence of some unique side effects. We'll talk about the practical management of that. And then what we learned at South Lake as we implemented the bispecific program, things that we had to do, things that worked, things that didn't. I can even show you some of our pre-printed orders, and we'll have questions at the end. Bispecifics, what are they? It's an antibody, and it basically attaches to a cancer cell and a T cell, or what we call an NK cell. And a lot of things are liberated here, lysozymes, cytokines, and this is what happens to the cancer center. So really bispecifics bring the immune system into close proximity of cancer cells and cause cell death. So that's about as complicated as I'll get for mechanism of action. Just for nomenclature, we use the term bispecific antibody, which is the majority of what we have. There's 2 epitopes, one attaching to a T cell, the other attaching to a particular tumor. There are these elements called bispecific T cell engagers. They're not full-on immunoglobulins, complete immunoglobulin molecules. So blinatumomab for ALL is something you're probably not giving that at your site, but this is what a bispecific is. Again, the idea, it attaches to 2 different epitopes and brings a white cell or a T cell in close proximity to a cancer cell. resulting in cell death. So that's just so this term BiTE refers to bispecific T cell engager. The majority of what we're dealing with are the bispecific antibodies. And what about these? Well, bispecifics, they can target many different proteins on different cancers. So if you look in lymphomas, CD19 and CD20 are what we tend to target on the lymphocyte. On plasma cells, BCMA, that's a very well-expressed epitope on plasma cells. And so the bispecific will target that. I showed small cell lung cancer. It's the DLL3. That's tarlatamab that some of you may have used it. I'll tell you a little bit about that. So really, it's really targeting all kinds of different tumors, but most headway has been done in the hematologic sphere. There's work that's expanding in the solid tumor sphere. And one of the drugs, tarlatamab, is available for small cell lung cancer on a compassionate program. These drugs, what are they? Well, they're given generally one every, after you've titrated someone up over the first month or so, and we'll talk about that. They're given once every week or two, and then eventually monthly. It's used in a variety of disease areas, and it's actually, they become standard of care for a number of indications, and I'm going to touch on those, both by public funding or full universal compassionate programs. There's an issue about the cost of administering it in terms of tubing, and if they need to come into hospital, that's a separate issue. Lots of clinical data for these drugs. And if you look at sort of where drugs are for public funding, uveal melanoma, extremely rare, we kind of park that, but large B-cell lymphoma in third line, these two drugs are funded, Epcor and glofitamab are funded in the current system. And then we get down to myeloma therapy. Teclistamab and elranatamab have enjoyed universal funding. Talquetamab not yet. And tarlatamab has actually been available as a compassionate drug as well, as a universal compassionate program. So there's, we've given 5 of these drugs at our center over the last year, and the compassionate programs have been quite general. So these drugs are here, they have data to support them, and they're being used. I just want to make a distinction between CAR T and what I showed you were these antibodies that you can pull off the shelf, start the patient on the next day if you need to, and get it going in the community, versus chimeric antigen receptor T cell therapy, where someone has their T cells collected downtown at Princess Margaret. They get sent down to possibly California, where over 3 or 4 weeks they get transfected, and they eventually express a chimeric antigen receptor on their surface. These CAR Ts are grown in the lab, and then they get infused back into the patient to essentially do the same thing I told you with the bispecifics. This is a so-called one and done CAR T. It is available now for lymphoma and funded a variety of different indications, and will be funded shortly for myeloma as well. So that's in the background, because one of the things with these newer therapies is, do we give a bispecific or CAR T? And this is some data for lymphoma, aggressive B-cell lymphoma. The long and the short is CAR T probably has a bit more efficacy, but also higher adverse event rate, particularly these unique cytokine release and neurotoxicity syndromes. So this is the milieu that we've got these drugs. And the thing about bispecifics is they're in your pharmacy. You can start them shortly, and it's handy to give, and the patients don't have to travel 2 hours down to PMH. And again, it takes about 6 to 8 weeks to get someone a cart, and that can be problematic sometimes. And this is just really talking about CAR T versus bispecifics. The reason I mention this is a number of the indications for third line lymphoma. There's CAR T available and there's bispecifics available, both funded in the public system. So then a decision is, which one do you give? Generally, if someone is suitable for CAR T, we suggest the CAR T and we refer downtown for that. Many people are not, because of physiologic issues or logistic and support issues, and therefore the bispecific is something that we'll go to. There are a number of issues here around the B-cell aplasia, the use of IVIG and other things, but that's the gestalt of CAR T versus bispecific, to frame it for you. And so what do we really have in Ontario? As I've shown you, a couple drugs for myeloma, although elranatamab from Pfizer may not be available too much longer. I'm not sure where that's going to go. A couple drugs funded for relapsed diffuse large B-cell lymphoma. I talked about ALL drug, a small cell lung cancer drug. Third line is available, compassionate program. And then this drug that I have trouble pronouncing, let alone having used for uveal melanoma. I'm going to just show you very brief data on 2 or 3 indications, then we'll get into the practicalities of these drugs. This is teclistamab for myeloma, and interestingly, it's rare we get drugs funded from phase 1 and phase 2 data alone, but the strength and the breadth of the data is so strong here that our public funders have deemed this as game changers and have funded it. So in myeloma, it's used after 3 lines of therapy where they've been exposed to generally proteasome inhibitors, IMiDs, and CD38 antibodies. So it's often they have to have had at least 3 lines of therapy in this trial. And in this trial, the average age was 64, and they'd had, get this, 5 lines of therapy and had their disease for 6 years. And for those hematologists, they were triple class refractory and triple class exposed 77 and 100% of the time. So a lot of drug exposure, real world patients. And the long and the short is the response rate 63%, and the complete response rate is 38%. So very powerful. And the duration of response here, if you get a CR, your duration of response approaches 2 years. So 40% of patients get a CR, and those patients will have a response. This isn't just living, but response before they relapse of 2 years. So again, quite powerful data. And that's just more of the same. Couple things. So on, the 2 things on the side effects, the cytokine release syndrome and ICANS. I'm going to speak to these in detail, but CRS is very common. About 70% will get it. We'll talk about that. But in terms of grade 3, 4 CRS, where they're going to the ICU, they need pressor support and other things. Very rare. Now, this is majestic data for teclistamab. The different bispecifics vary in their incidence of CRS and ICANS, but the themes of CRS being common, but serious CRS being relatively rare is fairly consistent through the different bispecifics. And here's the Health Canada indication for teclistamab, at least 3 lines of therapy. Importantly, for the hematologist, they have to have had a CD38 as well as a PI and an IMiD exposure to get funding for this. And elranatamab enjoys the same support. This is epcoritamab for relapsed large cell lymphoma after 2 lines of therapy. So diffuse large B-cell lymphoma, most people, internists, everyone's familiar with this because they tend to come into emerge with aggressive disease from time to time. And this is a patient group, 64, median age here was 64. Most of these patients had diffuse large B-cell lymphoma. About 30% were transformed from follicular lymphoma. And median number of lines of therapy here was actually 3 in our system. It is funded after 2 lines of therapy. Here you'll see US data. 40% had a CART before a bispecific. Yes, you can give these drugs after CAR T therapy, by the way, in our system. This is the step-up dosing. So this is an example of what we call step-up dosing for a bispecific. They're all a little different, but here 0.16, 0.8, and then 48 milligrams. And here's where we see the CRS and ICANS with the first 3 doses most commonly. I'll show you a little bit more detail on that. But here's the response across subgroups. So the response here is sort of in the 65, 70%. And you see the CR rates across different ages, diseases, whether they've had CART or not. Again, you're getting CR rates of 40, 45%. And durable complete response rates here, 75, 76% of the year. And that goes out in people who've been in complete response. So, response rates, CR rates around 40% plus. And when you get a CR, you stay in remission for a good long time. You need to stay on treatment for this drug, which is generally delivered weekly, followed by bi-weekly, and eventually to monthly dosing. And here's the indication after 2 or more lines of therapy. The same goes for a second bispecific, glofitamab, which is available also as is epcoritamab by a universal program by the drug companies. And then the last bit of data before we get in the nuts and bolts of these drugs is tarlatamab in extensive stage small cell lung cancer. We see a lot of that. This is the Delphi 301 trial. 190 patients had at least 2 lines of therapy here. and response rates here of 40% in third lines, which was good. And what's important with this trial, it's the proportion of patients that stay a lot, like the survival here at 9 and 12 months, 60% of patients are alive at 12 months. And these are patients getting third line therapy for extensive stage small cell lung cancer. So this, while the response rates aren't quite as high, there's something going on with the biology here that changes something. And so we've given this drug, I think, to 4 or 5 patients. I think actually with Shaq Kassam at our center, we had the most patients treated with tarlatamab in the country. But again, this was a fairly easy drug to give. And it can make a difference for patients. So there's my case for why we're so interested in bispecifics. And why we really need to get them rolled out to large community hospitals such as your own. What about, so the reason all the internists and hospitalists and the intensivists are on this call is because what are these hematologists and oncologists doing to these patients? And what are all these syndromes that they're creating that we have to manage? And I get that. I did a lot of internal medicine before I went into hematology. Here's we'll talk about these 2 unique syndromes, cytokine release syndrome, and this is a tongue twister, immunoeffector cell-associated neurotoxicity syndrome. Let's just call it ICANS for short. The timing and duration varies from bispecific to bispecific, but all the themes hold. Generally occurring during step-up dosing. What I mean by that's largely the first month of therapy for these drugs. And most centers, we are admitting to hospital to observe them as inpatients with variable admission schedules. I'll touch on that detail later. There is a move to get initiation of these drugs as outpatients. I'll touch on that as well. We're participating in a trial looking at outpatient teclistamab. What is cytokine release syndrome? I hate progressive slides, but the long and the short is when the bispecific antibody interacts with both the tumor cell and the T cell, it initiates a cascade of inflammatory cytokines, which then recruits a lot of other cells, which recruit a lot of cytokines all up here. And what does cytokines do? They give you fever, you get tachycardic, you drop your pressure, and you can get organ failure. That's what CRS does. The classic symptom of this is fever, by the way, and we'll touch on that. This happens generally within 24 to 48 hours of dosing, and again, particularly during step-up of the drug. And so here's sort of the number of things it can do, but it's a lot of cytokines, capillary leak, and all the things that go with that as hospitalists, intensivists, and the internists you're familiar with. And I'm not going to beleaguer all of this, just to say that generally, fever is almost always there as the harbinger syndrome. This is from, there's a cancer care, there's lots of cancer care Ontario data, but in terms of what we do to try to ameliorate or prevent CRS and ICANS, pre-medication for these drugs does include steroid, antihistamine, and Tylenol in variable doses. Sometimes it's methylprednisolone, sometimes it's prednisone, sometimes it's Dex, and it varies from drug to drug. But generally, steroid, antihistamine, and acetaminophen are given. We'll talk about tocilizumab being used in the prophylactic setting versus in the treatment setting, but that's something that's occasionally done. And there's enthusiasm to use tocilizumab, which is an IL-5 antibody in the outpatient setting and giving it prophylactically to try to ameliorate or diminish the chances of CRS. So when people come in, we bring them into hospital, we give them a shot of whatever drug, say it's epcoritamab, because I'm going to use that example today. What we monitor for that is usual vitals, including temperature, and I'll show you our orders for this. If someone develops fever or hypotension or a bit of hypoxia, then we actually have a pre-printed orders that kick in. They get assessed by the local internist that's covering. Lab is drawn, infectious investigations are drawn, cultures are drawn, chest X-ray, and therapy with a steroid is initiated, and we'll talk a bit about that. We have standard grading for cytokine release syndrome. And so on our ward, we have charts with this. This is also in the patient's chart. So when a nurse is doing her assessment, she's aware of this as well. Grade 1 CRS is just fever. Grade 2, some hypotension responsive usually to boluses of 500 mils of normal saline repeated once or twice, and or they may require a little bit of low flow oxygen. Grade 3 vasopressors, this is where we're calling the intensivists. Generally, this is ICU monitoring at this part going forward. And grade 4, multiple pressors, additional support, ventilatory support. The grade 3 and 4, as I mentioned, are very uncommon. Treatment for these grade 1, just fever. Again, we are managing these patients as inpatients on our titration on the step-up dosing. And so the initial thing you can do is give some acetaminophen, but our threshold's pretty low to give a single dose of dexamethasone, 10 milligrams. This is in our pre-printed orders, as I will show you. If the fever persists, giving a dose of tocilizumab can be considered. It's 8 per kilogram, standard dosed up to 800 milligram dose. You can give it Q8H up to 24 hours, and I'll talk a little bit more about that. But CRS grade 1 CRS managed easily on the floor. And again, we have pre-printed orders that deal with this. We've had no issues with grade 1 managing this at our center on our cancer floor. And that's just highlighting things. Grade 2, pressure may be down. Maybe the oxygen saturation is 87%. They're going to get a chest X-ray. You've set off cultures. You may have started empiric antibiotics. They've had a dose of steroid, and by this point, they should be getting a dose of tocilizumab as well. And this really just emphasizes the same thing. The dex goes to 10 Q12, and we're generally administering tocilizumab at this point. Again, this can generally be managed on the floor by the team fairly effectively. We do have our CCOT team. You may have something similar in your hospital that has come to eyeball the patient. They've been involved with these patients, but often we've kept them managed on the floor. Often when you initiate therapy for these things, 6 hours later, the patient's much better. The fever can go away. They just feel better. That's rather gratifying. The grade 3 and 4 are sicker patients. They're going to the ICU. They're going to be on monitoring. They would be dosed with tocilizumab up to 3 to 4 doses. If they're getting sicker, we may give anakinra, which is an anti-IL-1 antibody. And then a lot of this is supportive care with the utilization of steroids as well. I don't want to drill too much into the details of this for the purposes of this talk, but this is to just give you the flavor of what happens. And the CRS is no different. It really, other than will escalate to 20 Q6H, which I'm not, it's the usual. If some dex isn't working, give more. What it's worth. By this point, though, we're often giving a second interleukin blocker. Anakinra is the one, and then cetuximab, I think it's an IL-6, if I recall. I've never given cetuximab. I want to talk a little bit about ICANS syndrome. This is the neurologic syndrome. So all these cytokines are floating around. They cross the blood-brain barrier. You get edema and trafficking of T cells into the CNS, and you basically get encephalopathy with or without focal signs. You may get intracranial hypertension. You may have seizures as well. It can sometimes accompany CRS. People who get ICANS often have CRS. People who get CRS rarely have ICANS, just FYI. And so when our patients are admitted to hospital and they're getting the titration up doses, we do this every about 6 hours. This is sort of questions. There's questions to orientation. There's 4 points here. Naming 3 objects, commands, writing, attention, and they get a score out of 10. It's called the ICE score. Here we're doing it, I guess, twice daily. We've had discussion about 3 and 4 times daily. This takes nursing time. The nurses as inpatients have been in service to do this. And then the ICE score then translates to a grade. Here you're spontaneously awake. You might have misnamed an object and your writing may not be so good, but you're wide awake otherwise. Here you need to be nudged a bit to be awake. And this is, when you're getting to 0 to 2 here, awakens only to tactile stimulus. I can tell you, we've not had this yet, but you would be going to our ICU. And we're getting our neurologists involved as well. Here's the actual treatment management for it. The one thing we do is a single dose of dexamethasone. Say the ICE score is a little bit depressed, nothing else going. There's nothing to be lost by a single dose of dexamethasone. Our patients are already admitted to hospital, and if they're grade 2, they're on regular dexamethasone. Tocilizumab in and of itself is not used for ICANS in and of itself. It's often given because there is an element of fever, wonders about CRS, and often the tocilizumab is given with dexamethasone. And I have pre-printed orders that I can show your group around all of this, that it's somewhat algorithmic. So again, I just want to give you the flavor. When they're, when they're down to grade 3 and 4, they're in the ICU, our neurologists are involved, they're getting anti-seizure medications, etc. And we've not seen serious ICANS at our center. So I'm no expert in the management of it. So that was a bit of a whirlwind, but I just thought I'd get into a case, what we do at Southlake, what our orders look like, that kind of thing. And I hope you'll find that helpful. So this is an example of someone we treated with epcoritamab for relapsed diffuse large B-cell lymphoma. The story is he had R-CHOP, he had 6 cycles of R-CHOP, remission. A year and a half later, relapsed. He had a RGDP salvage and a transplant. That would be an autologous transplant. Relapsed 6 months after that. He was not a CAR-T candidate. I don't know the reasons for that. That's fine. And it was felt that, bispecific was appropriate. So he came into our center. We admitted him to get EPCOR. We admit for 1 or 2 nights for the 2 step-up doses. So he had the first step-up dose. He was here for a day or 2, went home, comes back a week later for step-up dose 2. He gets the dose, and the next noon he's walking around, and he has a fever. He's got a lowish blood pressure. He's thinking, well, no hypoxia, just doesn't feel quite so well. So here we go. Is this CRS? It fits the criterion of it. It's about a day after his step-up dose 2. And so now I'm going to tell you, how did we prepare for this kind of patient and how it's managed? So I'm going to take a step back. Our hospital, we're about 500 beds. You're a big place, Scarborough General, I know. And we've got 11.4 med oncs and hemes, of which 6 are hematologists. We do have a 6 cancer floor that has 23 beds. It's run by the hospitalists, med onc and heme on call. We're up there quite a lot. We've got NPs up there as well. We give a lot of very active therapies up there, high-dose methotrexate, day 1 autologous transfers, etc. We have a big ICU. We have neurology, ID, respirology support. I think all of these are important for a center administering bispecific therapy. So that's the background to our center. About a year and a half ago, when we started talking about bispecifics, I think the biggest thing that's critical is buy-in from your senior leadership team, both in your medicine cancer program and the hospital itself. This is something, as you've seen, is interdisciplinary, and really we need the support of all our physician colleagues in the different specialty areas around this. I think you need a physician champion. I was kind of the physician champion to start, and then I handed it off to Jay Jayakar and Shak Kassam, who really ran with this. But you need a physician champion, I believe, to really make it work. We formed a multidisciplinary working group, pharmacy, nursing, our inpatient managers, our educators. We had physician reps from medicine on there, and then we had ad hoc representation from the ICU and neurology. We looked to mentors, Princess Margaret, and then Phil Curvilla and the team there at William Osler really moved on this, and we talked to them. How did they do it? We took their orders and we jigged them for us, and I'll show you what we came of that. And then really just we got all the stakeholders involved, and I'm really impressed you've got so many people on this call. Clearly, you've got people interested. And again, it was the internists, the hospitalists, the ICU staff, ID. We had the emergency staff engaged too, because sometimes these patients can be discharged 48 hours and maybe they'll just develop this CRS a little late. If they come to the emergency room, how does that patient flow work? That's important. And I just call it basically a glorified febrile neutropenia because they need to be processed fairly quickly. So that was sort of the nuts and bolts of what we did to start. And when we started talking about this program, we had some challenges that really needed to be addressed. I think the physician concern was, oh my God, we're going to be called every night at 1 a.m. And this is understandable with people with fever, shortness of breath, and hypotensive. And that is not the case. I have to assure you that I'm on call 1 in 5. We don't do inpatient call, but we're 24/7 as the hematologist or med onc on call. The ward for these patients, when they're on the ward, they know that the team can call us directly too, so we can provide guidance. This just does not happen that often. We've treated quite a number of patients, and you don't get called every night about these. So that's my first reassurance, because understandably, as physicians, we're all being pulled to do more. This has gone really quite well. Inpatient capacity concerns. Are these patients going to swamp our inpatient beds? No. Despite the number of indications I've shown you, despite the fact this is standard of care, the actual numbers of patients that end up being well enough to get a third line treatment for a variety of these conditions, there's not a lot of them. So we're probably admitting a patient every 2 to 3 weeks for a bispecific start. They're in, and then when they do it, they may be in for they might come in for 5 to 7 days if it's teclistamab, and then they go home, and then the rest is as an outpatient. So the reassurance here is these patients will not overwhelm your inpatient beds. Really, the hospice internists, a lot of you on this call, I think, you guys are important just to understand a little bit what these syndromes are. They can be effectively and easily managed, generally with supportive care, ruling out infection, steroid, tocilizumab. I think the important thing with our hospice internist colleagues is that you can call the medical oncologist or the hematologist to have a discussion anytime, and that really helps. Same goes for the ICU. Our ICU team was actually quite keen to get involved with this, and I still remember one patient who was challenging a bit and declining a bit, and I phoned and I was going into this big apologetic explanation, and the ICU, the intensivist, basically told me to shut up. He used to work at Roswell Park. He gets it, and just transfer the patient. So, there again, the ICU is happy to help these patients. We've had, I think, only a couple patients go to ICU on this. It is not common. Neurology was interested. We educated them. And then importantly, there's a big nursing and physician education component here, particularly because the nursing staff are doing the assessments for the inpatient step up around CRS and ICANS. And I'm going to show you I showed you some of the scores and evaluations they do. So that was something really important, is to make sure our nursing staff was comfortable with that too. We created order sets. I'm going to show you that. Patient education materials, because when these patients go to the hospital, they need to know, well, when do I call? What do I do if I get a fever? And it's sort of similar to febrile neutropenia with the twist, and they have a special card I'll show you. So when they are discharged, if they do report back to the emergency room, they know they get processed in a special way. They call the hematologist or medical oncologist who's on call. We generally get them up to the ward, or they're managed in the emergency room fairly quickly, and we'll have a chat with the emergency doctor. That piece has worked pretty well, but the importance of engaging our ER colleagues around that. And as I said, it's really just a variant, I believe, on febrile neutropenia, which I think has worked pretty well. So our current process, if we identify someone to go on a bispecific, so we talked to rounds yesterday, a third line patient with relapsed aggressive B-cell lymphoma who is because of age, comorbidities, and distance, will not go downtown for consideration of CAR T. And so they're going to be given a bispecific for third line. I showed you there was 2 of them, epcoritamab and glofitamab there. So what do? We see them in clinic. We start the process. We make sure we can get the drug. If it's a compassionate program, we make sure it fulfills NDFP funding criteria if it's funded, which it does in this case. We plan to admit likely the next week. Then we make sure the medication reconciliation's done. No active infectious issues going on. IVIG is something we use largely for most of these patients because they do get B cell aplasia. Their immunoglobulins drop to their boots. And so we're giving these, I should mention immunoglobulin because we encourage subcutaneous immunoglobulin use, which you can do at home. So we generally put them on monthly replacement therapy while they're on treatment. And then really we have a kind of a visit about a week later, and then they end up getting admitted on a Monday or Tuesday. The actual scheduling depends on the bispecific and the CRS ICANS risk. So if you know that the ICANS or the CRS is going to come 1 to 2 days after the shot, you're not going to bring them in on a Friday for treatment, right? So we'll bring them in on a Monday or Tuesday, and then they're home on the Wednesday or the Thursday. I think what I'll do now is I actually, first you can hear me and see my screen okay? Can I just get a nod on that?
Yeah, we can see it
Good.
here.
I'm going to just bear with me here. There we go. So I'm going to show you just 3 forms that we used at our place. Can you see that okay?
Yeah, we can see it.
Yeah. This is this serves as our general admission form for patients being admitted for bispecifics. So you'll have your general medicine admit forms pre-printed. This just has some twists to it. And the big twists are here. You'll see, activity and all the other stuff, but immune effector cell grading on admission, then Q8H. So that's that ICE score I told you about. And then CRS grading on admission. So the nurses have a set of vitals that they do, and they call that their CRS grading, and they chart that in a particular way as well. The rest of this form is like your general medicine admit form, so I won't beleaguer that. So this is sort of what we have is a bispecific order form, which is like 3 lines. It's like give EPCOR 0.16 milligrams with the pre-meds before. It's a very short order. This is the general admission form. And then I'm going to show you our cytokine release. So here we go. So this is the CRS management form. So the nurse is doing the vitals, and he or she, if they identify a fever of 38 or greater, they proceed to the CRS. So they'll look, is there hypotension? Is it grade 1 or grade 2? Some lab investigations, including infectious screens and a chest x-ray. And then, antibiotics, pip/tazo versus meropenem. In most cases, antibiotics are given. They don't always have to be. If it's sort of classically 1 day later, it's a little bit of fever, but most of us tend to give some antibiotics. And then actually management, and it is a steroid to start, and here it's either Dex or the reason we have other steroid is some of the other bispecifics have methylprednisolone, and so we left it like this to make this jive with others' care plans. Generally, dexamethasone is quite adequate. So long and the short. So this is sort of what we have for grade 1. Grade 2 is very similar. It's giving you fluid orders here as well, and you're giving tocilizumab for grade 2. Again, standard dosing up to 800 milligrams. And then it says if the symptoms are unresolved, you can repeat that for a total of 4 doses. Generally, I generally stop at 3, and then you need to consider other issues, but that you need to give it sometimes 24 to 36 hours at least. And patients, if they've got grade 2 CRS, should be getting regular steroid as well. Grade 3 and 4, these are a little bit moot because once they're into grade 3, I'm calling our CCOT team and the ICU teams assessing them, and they're likely going down to that neck of the woods. And then these orders are adapted into the ICU workflow. So I'm not going to spend a lot of time on these. The point being that for grade 1 and 2 CRS on the floor management with nursing orientation, this has worked quite well for us. And it does, orders can be given over the phone. Importantly, a physician should be assessing these patients within, 1 or 2 hours. So if it's at 1 a.m. and this happens on our floor, we'll ask if the hospitalist or internist can come to see the patient. And that has worked. That has not needed to happen. I think it's happened once or twice. I personally have never had calls in the middle of the night about these patients. And, I do 1 in 5 call. I'm going to just show you the one other well, I won't let me click on it because that's in the way. Anyhow, we have an ICANS order set that's sort of similar to this in terms of ICE scores and grade, that sort of leads you along, coaches you on the dosing of the steroid, neurology consultation, need for EG, MRI, that kind of thing. And so it's very similar. And again, we would be happy to share these with you. Yeah, let's see, we're pretty good with time. I'm just gonna go back to this case. So, this guy develops a fever 24 hours later with a little bit of drop in pressure. And so this is data for what epcoritamab does. And you'll see that this is the incidence of CRS from day 1, day 8, and day 15 dosing. Not very common at all for the first 2 doses. Almost half the patients with the full dose, that's day 15, will get CRS. The median time to onset is really 1 to 2 days. But here you'll see, from the first full dose, it's generally the next day that they may develop fever, hypotension, a little bit of hypoxia. You're going to treat that with steroid and possibly tocilizumab, and it tends to settle very quickly. I find sometimes within hours it settles, in fact. So this is specific for EPCOR, and different bispecifics sort of have a different timing. So when we admit our patients for inpatients, we'll admit them for 1 or 2 nights for these 2 doses, and we'll plan to admit for 2 nights after the full dose. That's what we have been doing. We try to get them to the floor early and dose them early. And this is just showing you CRS, for the first full dose, only 3%, only 3 patients here had grade 3 disease, grade 3 CRS. So very uncommon, hardly seen with the first 2. So generally it's some fever, a little bit of hypotension, maybe a little bit of hypoxia. This patient we cultured, gave steroids, 1 dose of toci, fevers resolved quickly, observed another day. They went home, culture's negative, or they went home 3 days later, but a day later they were fine. We probably held them because we were a little paranoid another day or 2. But that's an example of sort of mild CRS, easily managed on the floor. This is ICANS specific for EPCOR here. All grade is only 6%. It's not very common. Tends to occur after the 2nd week. It resolves fairly quickly. It's usually managed with steroid alone. And you'll see relative to CRS, it's associated with CRS about 60% of the time, or it can follow CRS. So it's often intimately associated with cytokine release syndrome. And then these patients go home. We treat them as outpatients. We manage their cytopenias. Some of them need GCSF. You should not use growth factor while they're being titrated up. That's because there's lots of cytokines around. So we use that, though, after cycle 1 or 2, we will use GCSF if they have persistent issues with cytopenias. We give IVIG lately, infectious issues. We do manage them with valacyclovir or acyclovir. We haven't been using antifungals because they don't tend to be neutropenic, and so that hasn't been as big an issue. This is the wallet card they take to emerge if they have to. I mentioned tocilizumab, prophylactic dosing. That is dosing it to ameliorate or decrease the chance of CRS. That could be considered. We've only been doing it, we've been doing it a little bit, but with our pharmacy colleagues, we're only doing it in people who are higher risk. So we consider doing it for the 3rd dose of the EPCOR. But because CRS is quite easily managed, we haven't really done much prophylactic dosing. This may become a lot more popular as we look to outpatient titration up. And again, we're participating in a pilot with the PMH around that. I'm almost done. This is my reflections page. I know I've been going very quickly. I mentioned different bispecifics have different step-up schedules. So here's an example. Teclistamab is dosed, that's for myeloma, is dosed day 1, 3, and 5. And so we bring them in for a week and just dose them the day they're there, day 3, day 5. If they get CRS or something, and you have to delay 2 or 3 days, like you can delay up to a week, and then you can just pick up on the dose of the step up schedule again. But if there's an issue, infection, or more commonly fever not sorted out, there may be delays on the step up schedule. I showed you epcoritamab as an example. That's weekly admissions for the first 3 doses. One wonders if you really need to admit them for the day 1 and day 8 dose, given the very low incidence of CRS, which tends to be very mild. If that's the case, I think you need effective ways to manage these patients as outpatient. They present to the emergency room with a card. What are their symptoms, and do they get steroid and or tocilizumab fairly promptly, working with our emergency department colleagues. Glofitamab may only be required for day 8. I didn't show you that in detail just because I didn't have time. After hours coverage generally has been the internist hospitalist in the hospital with the med-onc heme available 24/7. I've only had one call in the early evening about a patient that had a borderline fever, and the internist was seeing them, and given it was the first time they'd seen someone like this, they quite appropriately gave me a call just to make sure things were okay. And then our CCOT ICU team, again, is familiar with this group of patients. Earlier is better. The only thing I say there, using these drugs, it's better if you've got low disease burden versus high disease burden. That's probably a paradigm in oncology. Sounds silly, but someone's got a huge amount of disease. These drugs don't work as well. If you get them earlier, ultimately in biochemical relapse in third or in fourth line, they can tolerate it well and they can do very well. The last person I did this to got elranatamab. He was 91. He drove his wife to medical appointments, I would add, and he reacted to teclistamab a year ago, so we had to go look at something different. But he did very well, and now I give him half dose every 2 weeks rather than a full dose every week, and he's doing fine. And I think my last point to reassure managers and the leadership is these patients will not overwhelm your system. I think that's it. There's lots of CCO guidance around this with the website, and I'm going to stop there. I hope that wasn't too fast and too whirlwind. I'll stop there. Thank you.
Thanks so much, Dr. Anglin. That was very practical and a great overview. So if anyone has questions, I think there's 2 ways to go about it. You can either put your hand up and ask your question directly, or type it in the chat and I can read out the question on your behalf. So I think while we're waiting for questions to come in, I'll start with the question. So I guess just like reflecting back now that you've done this program for a year, what are like 3 take-home points or 3 strategies that you've changed the program in the last year or so since starting it?
I'm gonna go back to my reflections page. So I think the first one is you need to engage all the stakeholders. And our experience here, and I'm sure it'll be similar at your place, I think most of the docs are happy to participate and help out. It's something new for them. It takes a little time, like, what is this thing? What are they? Demystify it. But at the end of the day, there's a couple of syndromes. You have algorithms in place. So the first thing is engage your stakeholders, which you're doing. The second thing is senior leadership has to support this because this requires a lot of nursing education, people being backfilled. Your nurse educator needs to be engaged. So the leadership team at all levels needs to be engaged to make this successful in my mind. What's the third thing? I think the biggest, the third pearl, I guess, is once it's up and running, there's not as many of these patients as you think. But you need to be ready because all of a sudden in 1 week you might have a couple of patients. I do think I didn't have much time to talk about moving to outpatient initiation. I think that will become much more the norm in another 1 or 2 years. And CCO will be supporting this as well, so we don't have to admit these patients because a lot of them come in, are bored for 2 days and go home. And if you're bored for a couple of days and get a mild fever, then you can come in. A lot of that relies on supports, how close they are to the hospital, these other usual logistic things.
Perfect. Okay, and I see Alexis has her hand up.
Thanks, Jesse, and thanks for a great and informative talk. one question I have is as you're putting more patients on some of these treatments, in your experience, have they been pretty good about presenting to your own hospital when they have concerns around them, or have they been managed sometimes in other hospitals that may or may not have access to these treatments? And has there been a plan for that?
Great question. No, we say you must come to our hospital, period. Like that's so, we do have where we practice, Alexis, we do have patients that come from quite a distance. So, I mean, there was one patient that was closer to Barrie, and I think we had this discussion that they presented there. They have the card and our name is on it to call it. But really what we say is really just come to our place. It's just easier because we've in-serviced everybody. And so we've not had a problem with that thus far, Alexis.
Thanks.
Sort of along those lines, I think you briefly mentioned this. Like you guys do give a card for patients, like a patient wallet card, so to speak. In speaking to our Emerge colleagues, I think one of their hesitations is they're worried they won't recognize that someone is on a bispecific soon enough, just because the names are quite long and fancy, and there's so many other different cancer drugs out there. And I think this is also more of a problem if a patient goes and presents to a hospital that does not yet have a bispecific program in place. So do you guys have any pearls of how we can help our Emerge colleagues recognize that person is on a bispecific drug?
Look at the card here. I'm receiving the following T-cell engaging drug. And it will say, and the other thing it says, what we do in our thing is the contact, like what we tell our patient, they present to Emerge, and we've told our Emerge, they can call us immediately. So they get fast track, and they can call the med onc or hematologist on call right away. So this is, there were specific cards that different companies have. So I don't know if we've even implemented this particular card, but the cards we've using, it's the same thing. This is a special drug, they need to go to the front of the line, and you can call the hematologist right away for guidance. And you'll see, if you can read upside down here, there's a brief thing on side. There's a crash course in CRS and ICANS on this card, which, but I think the important thing is this card says they're on that drug. And, the patient, we tell our patients part of education, you go to Emerge, you wave this in front of them saying, this is special. I need to be at the front. And we've only had a couple patients come through Emerge, and it was seamless. It worked pretty well.
Sounds good. Have you gotten false alarm calls, like the Emerge calling you about other drugs that they think are bispecifics?
I don't think I've had a false alarm call. No.
Sounds good. Perfect. I think there's something in the chat. So, oh, I think this question's directed to me. So do we have a timeline as to when SHN will be launching the stakeholders, so stakeholders are aware? We don't have a specific timeline yet. I think in our minds, we're hoping within the next half year that we'll get the program up and running. Like we've started to make the management protocols, and we're in the process of getting those onto Epic. So I think right now our tentative plan is within the next 6 months.
So you have some pre-printed orders and all of that, Jesse, that you're working on?
Yeah,
Like,
Allison was able to get samples of protocols from South Lake, Princess Margaret,
good. Yeah.
a variety of different centers. So we're just trying to look through them and see what would work best for us. It'll probably just be like an amalgamation of what other centers have been using.
Are you computer order entry at your place?
Yeah, so we're Epic based.
Yeah, we're just going to computer order entry on the wards in the next 6 months. So right now these are paper, but these what you saw are being embedded into a computer based when we go forward.
I really like the medical alert wallet card, especially again, the cut the line, I guess, is the instructions for what to do with the card. But I thought initially you could be sort of literal instructions for the patients to sort of cut the line in the Emerge to get attention.
Yeah, I think it's pretty good. I don't know. Are you an Emerge doc or
No, I'm a GI, so but
yeah.
again, do
If
remote
someone
medicine.
showed that card to you, right? Like they go, oh, okay, like it sort of gets your attention, right? So thanks. I think that works.
I don't see any other questions. Maybe I just have one last question. So Dr. Anglin, you mentioned ICANS monitoring. It seems like the nurses are doing the I score every 6 hours.
Actually, I think they're doing it every 12. I said every 6, but was it every 12 or every 8? I see, I can't even remember all the details to these protocols. I have to look back at our sheet, but anyhow.
For sure. I was just wondering, like, do you guys do neurovitals in addition to that, or just the I score is sufficient?
No, they're getting, I think they're doing, I mean, it depends what you mean by neurovitals, right? Like neurovitals in different places mean different things, but they're making sure the patient's rousable, they're talking to them, but that ICE score covers an awful lot, right? I mean,
Mhm.
if you get a 9 on that ICE score, you're working pretty well, right? But I mean, it's not something where we see sort of focal weakness in the right leg. So they're not doing kind of neurological strength testing and all of that kind of stuff.
Yeah. Okay. Perfect. Yeah, I think that's what we were thinking as well. Like really relying on the ICE score. Like sometimes I've seen, I think at PMH they were doing neurovitals with like pupillary reflex and motor testing and all that stuff. But I don't really think that's feasible for our nursing staff.
To be sure though, Jesse, I'd have to check our nursing team for that, because that's some of the stuff that happens behind. Again, there's a lot of the care of these patients, like any complicated therapy, it's our healthcare colleagues that are doing it. So what's involved with that? I'm not 100% sure, to be honest.
Okay, no problem. So I don't see any further questions, and we're at time. So thank you again for coming and presenting this to us today. As you can see, we have a lot of interest, and people are excited to have the program on board. So thank you so much, and thanks again to AbbVie for sponsoring this.
Thanks, everybody. Have a great day.
Bye.
Yeah, Brent. Hi, Brent. Did you want to say something? I'm just going to stop sharing, but yeah.
No, just wanted to thank you very much for a great presentation, and Dr.
Thanks.
Pang, thanks for moderating. That was excellent.
No problem. Take care.